Good morning, ladies and gentlemen. The topic of today's lecture is the skin diseases that are caused by Malassezia and some other superficial mycosis. In this lecture, I am going to discuss the Tinea nigra, black and white Piedra, and Majocchi's granuloma. So this is the end part of superficial mycosis. And in the next lecture, I will be taking the lecture on deep mycosis. So Pityriasis versicolor, which is also known as the dermatomycosis furacea, Tinea flavia, liver spots, or chromophytosis. It's a mild chronic infection of skin that is caused by Malassezia yeast and characterized by discrete or confluent, scaly, discolored or depigmented areas, mainly on the upper trunk. The disease was previously attributed to Pityriasis ovale and Pityriasis orbicale, which are the body's normal flora. But now these yeasts are reclassified in the genus Malassezia, and there are at least 13 separate species of these lipophilic yeasts that are included in this genus, in particularly Malassezia glabosa. Colonization of these species is especially dense in areas rich in sebaceous glands like scalp, upper trunk, and flexures. Microscopy of the scales of Pityriasis versicolor nearly always reveal thick-walled spherical yeast forms, budding from a narrow base, which is compatible with Malassezia glabosa, and coarse septate mycelium, often broken up into short filaments. More commonly, mycelium is observed together with oval yeast morphology, suggesting more of Malassezia furfur and Malassezia obtuse. In both tropical and temperate zone, the condition is more common in late teens and peak in early 20s. These are the time when the sebaceous activity is at the peak. The sexes are probably equally prone. Ethnicity is no known association. The hypopigmented forms are noticeable more in those with a darker complexion, that is skin type 3 to 5. Then associated diseases. Pityriasis versicolor is common in those suffering from Cushing syndrome and probably with malnutrition, but it does not seem to be more common in AIDS patients. P. versicolor in most cases represents a shift in relationship between host and the resident yeast flora. Predisposing factors. There have been many attempts to explain this susceptibility in terms of physical and biochemical abnormalities, but the problem is still unresolved. Similarly, studies of cell-mediated response have also produced conflicting results. The T cell inhibition by a lipid component of Malassezia cell wall has been reported. Malassezia species do not attack the hair shaft, nail, or mucous membranes, but pulmonary and systemic infections in infants on long-term intravenous lipid therapy is a well-documented systemic complication. So if we do a histopathology, it reveals hyperkeratosis, and small basophilic spores are seen in the stratum corneum. The rest of the epidermis and dermis is unremarkable. If we order periodic acid shift reagent, then these spores are highlighted and giving the spaghetti and meatball appearance. Pathology. The infecting organism is usually present in the upper layer of stratum corneum, and corneocytes demonstrate increased cell turnover. This is the reason of scaling and hyperkeratosis. Mechanism postulated for alteration in pigmentation include the production of dicarboxylic acid produced by Malassezia species, that is azelaic acid, which causes competitive inhibition of tyrosinase and perhaps a direct cytotoxic effect on the hyperactive melanocytes. The total epidermal pigmentation is reduced in the hypopigmented areas. The explanation of hyperpigmentation that is seen in the fair-skinned subjects remain obscure, although electron microscopy reveals abnormally large melanosomes in the hyperpigmented lesions. The causative organisms. Tinea versicolor is usually caused by Malassezia globosa and possibly Malassezia sympodialis and Malassezia furfur. It is known that some Malassezia species become mycelial more rapidly and have perhaps slightly greater pathogenic potential. Conjugal cases can also occur, and possibly that in some instances, infection does not arise from individual's own flora, but is transmitted from another individual. So that is also possible. You can catch it from your sibling or from your parents, and this is not from the normal flora. In warm climate, more hyphae are associated. Hence, tropical climates, the condition is more common. This is how the P versicolor on a fair-skinned individual would look like. The macules are pale brown in color with slight scaling. On the contrary, in a pigmented skin, these macules will give hypopigmented look. Wood's lamp examination is a useful examination in picking up and differentiating Pityriasis versicolor from other similar conditions like Pityriasis rosea, eczema, psoriasis, vitiligo, etc. So under the Wood's light, these scales of P versicolor gives a pale yellow fluorescence. You can see this pale yellow fluorescence. Clinical variants. Facial and scalp lesion involvement is well recognized in the tropics. Palmar lesions have been reported, although it's quite rare. In untanned, white skin, the affected areas are darker than normal, as I have told you, but they fail to respond to light exposure. They don't get tan more. Differential diagnoses include vitiligo and chloasma, but there is absence of scaling in both. Seborrheic dermatitis, Pityriasis rosea, secondary syphilis, Pinta, and Tinea corporis show a more inflammatory changes. Erythrasma is confused commonly, especially when the lesions are restricted to the flexures, but the commonly differentiating features are satellite lesions are not seen in erythrasma, and on Wood's light, erythrasma will give pink fluorescence rather than yellow fluorescence. Pityriasis versicolor is strikingly free from complications. Disease course, it's a chronic infection, although clinical expressions such as extent may vary over the time. And investigation, usually direct examination, direct microscopy will reveal spaghetti and meatball or banana and grapes appearance in KOH mounts. Usually we don't resort to skin biopsy, but if done, then the histopathological appearances have already been highlighted. Management. Relapse is unfortunately very common, whatever the primary treatment is. In all but in more resistant cases, it is probably Simplest to retreat each episode rather than resort to a long-term suppressive therapy. Patients should be warned that repigmentation may take several months. First-line treatment is generally topical azole antifungal therapy. With oral itraconazole, the organisms die rapidly after exposure to azoles, but in view of the thickened Malassezia cell wall, they are not rapidly cleared from the epidermis. Terbinafine 1% cream is effective. The main problem with the use of topical antifungals is the difficulty in applying cream on a wide body surface area. So alternate is solution of ketoconazole shampoo. 2 to 3 application of shampoo appear to clear most infection. Our second cheaper approach is use of 2.5% selenium sulfide in a detergent base or Selsun shampoo. It's applied again to the affected area and left overnight. In many cases, it is necessary to apply the material regularly every other night for 2 weeks. The shampoo is irritant and if inadvertently applied to the face and genitals. Second line treatment is itraconazole in a total dose of 800 to 1000 grams, usually given 1 capsule twice a day for 5 days. Fluconazole can also be used. The terbinafines, oral terbinafines are not effective in Pityriasis versicolor and hence should not be prescribed. Then a related condition called as Malassezia folliculitis. Malassezia folliculitis is most often seen in the same age group as that of Pityriasis versicolor, that is teens and young adults. Biopsy taken from typical cases show cluster of yeast within the follicle surrounded by inflammatory cells. Patients often report the development of lesions following a holiday in sun or may be found in patients who are acutely ill, for example, in intensive care units. Lesions are itchy papules and pustules, but no comedones, and are diffusely scattered on the shoulder and back. Itching and distribution distinguish it from the acne vulgaris, and so is the absence of comedones. Management: the condition responds well to oral itraconazole and less well to ketoconazole shampoo. So this is how Pityriasis folliculitis look like. Numerous papules and pustules on the trunk, and on histology, the infundibulum of the hair follicle is dilated with multiple spores of Pityriasis of Malassezia species. So the yeast form are conspicuous with PAS stain. Few other cutaneous disorders that are associated with Malassezia yeast. So from many years, it is known that the Malassezia yeast are found in large quantities in scales of seborrheic ecdermatitis, both on the scalp and elsewhere. It has become apparent that most seborrheic dermatitis or scaling of scalp, that is dandruff, clears on treatment with antifungal agents. So adult type of seborrheic dermatitis appear to be directly related to Malassezia yeast, but not to a single species. Malassezia yeast have also been associated with confluent and reticulate papillomatosis. However, their presence in this condition is not invariable. Finally, there are variants in psoriasis that has been termed as sebopsoriasis, where lipophilic yeasts may have a pathogenic role. So 3 conditions: seborrheic dermatitis, sebopsoriasis, and reticulate and confluent papillomatosis are associated with Malassezia yeast. Then another topic is the Tinea nigra. It's an asymptomatic superficial fungal infection caused by Horty-Wernickeii. It generally affects skin of palms and is characterized by deeply pigmented macular non-scaly patches thought to be acquired by direct inoculation into the skin. A rare disease, occurs sporadically in Americas, Caribbean, South Africa, Australia, Europe, and Far East. Can occur at any age, but rare in childhood. Pathology, there is thickening of stratum corneum in which hyphae are present. Incubation period is from 10 to 15 days and more commonly found in tropical climates. The condition is asymptomatic. Lesions are macular, sharply defined, but not scaly. More distinctive feature is the brown or black color resembling silver nitrate stains. Palm is the most commonly affected. Other area of body is sole and rarely neck and trunk. Differential diagnosis. The black color and absence of scale differentiate this condition from P. versicolor. Pigmented lesions of Addison's disease, syphilis, pinta, and junctional nevi of palm may have to be differentiated, and mycological examination of scales is usually required. This is how Tinea nigra would look like, a well-formed, hyperpigmented rash on the palmar aspects. Microscopy of infected epidermal scales in potassium hydroxide mounts reveal abundant brown, branched, closely separated hyphae up to 5 micrometer in diameter with elongated budding cells. Inoculation of specimens into the sebrod agar and incubation at 30 degrees centigrade yields slowly growing colonies. Management. First line treatment is topical azole creams such as iconazole and ketoconazole. The condition is also responds to topical application of fungicidal preparations like butanafine. Benzoic acid compound or Whitfield ointment is also effective. So these are how these spores will look like in KOH mount. These are pigmented spores and hyphae. Then black Piedra or Tinea nodosa. Black Piedra is a fungal infection confined to the hair shafts and resulting from formation of hard, dark, superficial nodules thereon. Black Piedra is caused by fungus Piedra horti. It's a rare infection, occur in humid, wet tropical regions in America and Southeast Asia. A prevalence of infection of 57% in subjects over 11 years. An infection is thought to be more common in male than in female. Black Piedra is characterized by presence of firmly adherent, black, gritty, hard nodules on the hair of the scalp or less frequently on the beard, mustaches, and pubic hair. The nodules are usually multiple, oval, or elongated in shape and vary in size from microscopic to 1 millimeter or more in diameter. And their thickness often tapers either from one end or the other end or the middle of to the edge. Subcuticular fungal growth may rupture the cuticle of the hairs and fungus may then grow on the outside of the cuticle completely surrounding the hair shaft and hair may fracture easily. The disease course is prolonged if untreated. This is how these black nodules of black Piedra would look like. In potassium hydroxide mounts, the nodules are observed to be made up of closely packed brown hyphae held in mass by viscous or cement-like substance. The Piedra horti is almost unique among the human pathogenic fungi in producing sexual spores in its parasitic phase. Management. Shaving or cutting of hair is the effective cure. To prevent recurrence, antifungal preparations like benzoic acid compounds are used. Treatment success with terbinafine is reported. White Piedra. It's a fungal infection that is confined to the hair shafts and results in formation of soft, white, gray, or brown superficial nodules caused by Trichosporon species. Agents of white Piedra in head hairs is now considered to be Trichosporon ovoides, while organisms report from crural white Piedra include Trichosporon incin, Eschai, and Mucoides. a bacteria belonging to a new species of Brevibacterium macbrellineri, known to have a synergistic role in the infection. The infection occurs in South America, Africa, and Europe. It occurs in adults with no gender difference. Infection is asymptomatic. White Piedra is characterized by presence of soft white or light brown nodules on the hairs of beard and mustaches and genital area rather than scalp. Fungus grow both within and outside the hair shaft, and hair shaft may be weakened and break off. The nodules are transparent, easily detached from the hairs, and vary in size from microscope to 1 millimeter in diameter. The underlying skin is not affected, and there is no fluorescence under Wood's light. This is how white Piedra would look like. The difference between seborrhea, dandruff, and white Piedra. The dandruff affects the scalp, and white Piedra affects the hairs. There is erythema of the scalp in seborrhea, but the scalp skin is normal in white Piedra. Seborrhea is made up of dead skin cells that fall onto your shoulders. White Piedra does not fall on the shoulders, and nodules tend to stay clumped to the hairs. The Piedra nodules are soft and slightly gritty with a gelatinous look. They can be white, gray, or tan in color. Dandruff flakes, on the other hand, are lighter and yellowish white in color. Dandruff is generally found on the scalp and face, while Piedra affects your entire body. White Piedra cannot be treated by regular shampoo and require medical intervention. Nits versus Piedra. Nits resemble white Piedra, however, the nits are not easy to remove as the white Piedra. Lice cause severe itching while white Piedra does not. In pediculosis, lice are also seen on the scalp. Different on the scalp. Hair cast versus Piedra. The hair casts are thin, elongated, firm, whitish, cylindrical concretions, which unsheath the hair shaft and can be easily dislodged. Due to its clinical resemblance to pediculosis capitis, the entity is also known as the pseudonits. While hair cast encircle the hair shaft, Piedra does not. Hair casts slide easily along the hair shaft and do not result in hair breakage or damage. Hair casts are often of two types, the parakeratotic or secondary, or non-parakeratotic or peripilar idiopathic casts. Secondary form is more common and coexists with psoriasis, Pityriasis eminentia, seborrheic dermatitis, and hair shaft defects. The idiopathic keratin cyst is uncommon and is not found in association with any disease of the scalp or the scalp condition. These are how the nodules on the hair would look like. This is a black Piedra, then the white Piedra, then the nits, then trichomycosis, axillary or pubis. We have discussed this, hair casts, and trichorexis nodosa. The differential diagnosis of pruritus and distinctive shape of egg cast or pediculi should easily distinguish Piedra from the nits, but microscopic examination is desirable. The disease course and prognosis, if not treated, it's a chronic infection. Nodules of white Piedra are in the form of sheath. There may be excessive growth within the hair, giving rise to characteristic nodular swelling on the hair shafts. Management. As with black Piedra, shaving or cutting of hairs may affect a cure. Response to concentrated topical antifungals, azoles, and allylamines are reported but are unpredictable. Then the last topic of today is Majocchi's granuloma, also known as granuloma trichophyticum. Majocchi granuloma is deep and persistent, suppurative and granulomatous folliculitis that is caused by the fungal infection. It affects adults and commonly in developing countries. The associated factors leading to Majocchi granuloma include long-standing untreated infection, tropical climate, shaving or other cutaneous trauma, topical corticosteroids, and immunosuppression, for example, during chemotherapy or after organ transplant. Majocchi granuloma is due to infection of hair follicles at the site of cutaneous fungal infection. From the hair follicle, the fungi penetrate into the dermis and subcutaneous tissue, hence generating extensive chronic granulomatous response. So the granulomas are primarily perifollicular. Infection is most commonly caused by Trigophyton rubrum, Trigophyton mentagrophytes, Trigophyton tonsilans and vilation, and Epidermophyton flocosum. Non-dermatophyte modes like Aspergillus and Phoma are also etiological agents. The Majocchi granuloma present with irregular red scaly plaque in which there are follicular papules, pustules, or nodules. It is usually found on the lower leg. Evidence of fungal infection may be found in other sites such as Tinea pedis and Tinea unguum. So you can see multiple small follicular papules in the midst of a large indurated plaque. There are two forms of Majocchi granuloma. A perifollicular papule form is localized dermal infection and usually occur in healthy subject. Then deep subcutaneous plaque or nodules form arise in people with underlying immunosuppression. The folliculitis are acutely inflamed and fungi are clearly seen with visible surrounding shafts. As a consequence of cell injury, fungus is released into tissue producing intense inflammatory response. PS stain strongly positive these spores of Majocchi granuloma. Management. The recommended treatment is 4 to 6 week course of terbinafine, itraconazole, or grisofulvin. Topical antifungal agents may not be effective due to the deep invasion of fungi into the hair follicles. So this brings me to the end of this talk, and I hope to see you next time with the talk on another aspect of fungal infections. Thank you and have a very good day.